Hi everybody, we're back today with another focus video. It's been a while, but I have upgraded my software and hopefully we will have less bird noise. So let's get started with our third case of a patient that arrived for an emergency laparotomy, somewhat short of breath in the holding area. The images were done by Dr. Cameron Williams. I have to give him credit for some excellent scanning. So short of breath in the holding area, firstly you have to decide what you're going to scan and how stable your patient is. So this patient was stable enough that we could do a full assessment, and so we decided to do a full cardiorespiratory scan. Our first picture is, I think you can probably all appreciate what this loop is. Let me let you just have a look at it for a little bit before we start speaking. So structure you can identify is your left atrium, left ventricle, left ventricular outflow tract, your aortic valve, and your RV over here. Now, if you look at comparative sizing, you'd expect your aortic and your LA diameters in this view to be about the same, which would imply that this LA is somewhat enlarged. The other thing that we can see here is just on first view, this mitral valve does not seem to be opening very well. Now, what does that mean? Why does the mitral valve not open? Well, firstly, you could be cutting it wrong in terms of your image acquisition, but if you're imaging it appropriately, there's two reasons why mitral valve might not open very well. The first is that you have a low flow state, and the other reason is that there's something wrong with the mitral valve. If we look at this mitral valve, it looks anatomically reasonably normal. I don't see significant calcification of either the valve leaflets or the strut, the chordal apparatus. So this increase in septal separation or this decreased motion of the anterior leaflet, I think we would have to consider a possibility that this is a low flow state, so somewhat poor cardiac function. So those would be two things we could start putting on our potential short list for things wrong with this heart. So on to the next loop. So our next image is a parasternal short axis. And this sort of supports that initial impression that we potentially have a poorly functioning LV, and adds in a little bit of extra information here in that this RV looks fairly big, and this septum might be a little bit D-shaped, again, potentially not cut properly, so you have to always keep that in mind as a potential reason for the LV not looking around, is that you might have cut it in a more oblique versus perpendicular short axis. But this is definitely a significant decrease in LV function and quite a large RV impression here. Next up is our apical 4. I'll get you to have a little look at that first before we start speaking. See what you think of that. I'll remind you of the structures that we're looking at. You have left atrium here. You have right atrium here, right ventricle, and left ventricle. And a good apical 4 would have a perpendicular septum with the LV apex as the primary point of view. If your RV is more dominant and your septum is not perpendicular but kind of off to the side this way, it usually means that you've medialized your image acquisition and you have to move your probe more laterally. This is a very nice apical 4. We can see the heart is nice and long. We see very good definition of endocardium. We see the valves opening. And in this view, we see a little bit better mitral valve movement than we did in our parasternal long, but I would still suggest that there's a little bit decreased flow. In terms of contractility, what can we say here? We'll do a TAPSE later, but we'll look at RV base, RV free wall coming in here. And we'll look at LV function. So the septum does not look like it's contracting very well. Lateral base seems to be contracting well. This is kind of cut off a bit, but it does give you the impression that it's not working quite as well as you'd like to see. So definitely decreased LV function, and possibly I would say borderline RV function based on this picture. So our next picture was the TAPSE. So this is where you put an IMO through the RV base for that tricuspid annular plane systolic excursion. And this is definitely borderline. So still meets the expectation for normal, but borderline. Here we have our subcostal imaging. I'm going to get you to look at that again before I start speaking and tell me what you think. The structures here are LA, RA, RB, and LV. And the imaging is not completely optimal because we do slip from a 4 to a 5 chamber at times. But if we look at it while we have the 4 chamber view, I would suggest that this LA is at least moderate to moderate severely enlarged. And RB, I would again say, appears borderline in function, and the LV function is the same as before, decreased with that mitral valve not opening fully, decreased mitral septal separation. Our next image is short axis obtained in the subcostal space. These can be very helpful views to be able to get, which gives us that same impression: hypokinetic LV, hypokinetic RV, and enlarged both chambers. Next up is our IVC. So I'll remind you that what we look at in terms of IVC assessment is the diameter of the IVC as well as collapsing through respiratory cycle or during the sniff. So this is definitely a distended IVC. I don't know about collapsibility, but certainly this does not look like a patient who requires significant fluid resuscitation at this point. Our next images are respiratory. So here's a picture of the pleura. So looking at your ribs here with the pleura in the middle. And then generally we assess for the presence of slide and pulse to make sure that the lung is expanded and moving during anesthesia. In the pre-op area, in a patient's short of breath, we'd probably be more interested in what we're seeing here, which are B lines, which are these linear shadows that come from the pleura, and is a reflection of interstitial fluid. And these would probably be excessive B lines, which would give you the impression of either pulmonary edema or some kind of surge RDS picture. Our next image is the right subcostal area. And what we're seeing anatomically here is the diaphragm with the liver. We're seeing the spine that is continuing beyond where we would usually see it. Usually you only see the spine up to the border of the diaphragm here because the ultrasound beam cannot travel through lung because that's an air medium, and ultrasound doesn't travel through air, so you usually cannot see the spine continuing on. So this would be called a positive spine sign, and that would be because of this fluid here within the right pleural space. So this patient has a significant right pleural effusion. And then going on to the other side, we have left pleural effusion. So this would be the spleen and the spleen-kidney interface, again with the spine continuing beyond that diaphragm. That is your positive spine sign. And you can start seeing some atelectatic kind of liver looking like a lung peeking through here, which is collapsed lung base on the left. So what is our summary findings in this patient? In the holding area with shortness of breath, I think we've found some very useful information. We have biventricular dysfunction with LA enlargement, as well as likely pulmonary edema and bilateral pleural effusions. Pleural effusions likely could be drained preoperatively to improve your respiratory function, but in any case, you do keep in mind that this patient's lungs will need support during surgery, that you need to be careful with your fluid and continue to monitor the Zalvia and airway function appropriately. Thank you very much for your time, and hope to be getting some more focus videos to you guys soon.